And welcome everyone to our webinar today focused on ethics in sexual reproductive health. We are lucky enough to have an outstanding panel, and we're very excited, and I want to quickly introduce them, and then we'll move into their presentations because we have such a wealth of wisdom with us today that I don't want to take up 1 second too long. First of all, we're going to hear from Dr. Rebecca Cook, who is a professor emerita in the Faculty of Law, Medicine, and the Joint Center for Bioethics, the co-director of the International Reproductive and Sexual Health Law Program at the University of Toronto. We have our own Dr. Mary Ellsberg, who is professor and founding director of the Global Women's Institute and professor in the Department of Global Health here at the Milken Institute School of Public Health. And we have Dr. Julia Strasser, who is an assistant research professor and director of the Jacobs Institute here in the Department of Health Policy and Management at the Milken Institute School of Public Health. And I am Professor Melissa Goldstein, professor of Health Policy and Bioethics and Law in the Department of Health Policy and Management and the Milken Institute School of Public Health. So quickly, we're going to go to the presentations of our fantastic panelists, and we'll start with Dr. Rebecca Cook. Welcome, Dr. Cook. Thank you so much for joining us today.
Thank you, Melissa. I'm pleased to be here, and congratulations on bringing us all together on talking about ethics in reproductive and sexual health. I want to start my presentation by talking about the abortion care guideline of the World Health Organization. If you could get that next slide, please. Yes. So in 2022, we were all dismayed by the US Supreme Court's decision in the Dobbs decision. However, in 2022, the abortion care guidelines was published by the World Health Organization. It's a transformative document in many ways. It updates and replaces previous WHO abortion guidelines with a much stronger human rights focus than previous guidelines. It recognizes that abortion is both a health and a human rights issue. The guidelines are over 170 pages with appendices backing up their evidence-based research. There are summaries of the law and policy recommendations, which I will focus on today. The Center for Reproductive Rights has a summary on its website, and on our website, Joanna Erdman has an article talking about the methodology that was used to review systematically the evidence on the 7 law and policy recommendations. The first of those recommendations is to decriminalize abortion. Next slide, please. So the cornerstone of the law and policy recommendations of the WHO guidelines are that all norms, standards, and practices should promote individuals' health and human rights. That is, informed decision-making, free and informed decision-making, autonomy in decision-making, non-discrimination, and equality. In each of these areas of availability, accessibility, acceptability, and quality. In this framework, the World Health Organization borrows from the general recommendation of the Committee on Economic, Social, and Cultural Rights, which is the committee established to monitor state compliance with the International Covenant on Economic, Social, and Cultural Rights. So in terms of non-discrimination and availability, comprehensive abortion information and care should be integrated in all health systems. And they also discuss very significantly diverse service delivery models, telemedicine, telehealth, primary care, community outreach, and self-managed abortion. Accessibility, care must be available and accessible in non-discriminatory ways. Care must be geographically and financially accessible, and policies need to address systemic barriers and ensure access to vulnerable groups. In Canada, we've had very significant studies in terms of analyzing the gaps in service delivery. The Badgley report, which was issued in our 1970s, led to our decriminalization of our law in the late 1980s. So studies looking at gaps in service delivery are very necessary to ensure equitable access to abortion care. Acceptability, what the abortion care guideline means by acceptability, is respect for autonomy, preferences, and confidentiality, and it must be culturally sensitive and inclusive. The bottom line here is that acceptability means respect for medical ethics, which I will return to in the next slide. Also, in terms of the AAAQ, as it's called, one must adhere to evidence-based practices for safe and effective care and train accordingly. Next slide, please. So the International Federation of Gynecology and Obstetrics has an ethics committee that has issued ethical guidelines over the years. And this most recent, you'll see from the website there, this most recent compilation of these guidelines was issued in 2021. Now, some national colleges of obstetrician and gynecologists, such as the American College of Obstetrics and Gynecologists, also issue ethical guidelines. Most of, like FIGO, like the American College, most colleges of obstetrics and gynecology issue clinical practice guidelines that advise on safety and efficacy. But some colleges have very robust ethical guidelines, such as the American College and the International Federation. Now, I want to focus in on 3 of their guidelines. The first is confidentiality. So maintaining patient confidentiality is a cornerstone of medical ethics, ensuring trust between patients and providers. Breaches of confidentiality can lead to stigma, discrimination, and harm. So in terms of ethical practices and obligations, one must ensure free and informed consent before sharing patient data, protect sensitive information, and uphold ethical obligations to respect privacy. Now, these ethical guidelines have been very important in many different countries. For example, breaches of ethical practices in Poland. There was a case before the European Court of Human Rights where the court cited the FIGO ethical guidelines. They are used by other societies, such in Brazil, to show how some of their practices, in particular breaches in confidentiality, are outside the ethical norm. The second guideline, next slide, please, it concerns the right to conscience, guideline 14. So first and foremost, many ethical guidelines start with first respect the well-being of the patient. Here in Canada, our ethical guidelines of our medical association starts with first respect the well-being of the patient. But in many countries where abortion law is reformed, what happens is providers invoke the right to conscientious objection, often ignoring that women too have rights of conscience to access care, and doctors have rights to conscience to provide care. This ethical guideline of the FIGO Ethics Committee explains that you cannot compromise patient care or access to legally permissible care. So those providers that object on grounds of conscience must first and foremost respect prioritizing patient safety and well-being. First and foremost, to respect the well-being of the patient. As a result, those who object on grounds of conscience need to refer to providers and avoid imposing personal beliefs on patients. Now, there's a recent study in Argentina by Agustina Ramon Michael and Dana Rebka showing that following the reform in Argentina, there have been breaches of the right of conscience, such that care has been denied patients to which they were legally available. So this right of conscience has unfortunately been breached all too often. Next slide, please. Harmful stereotyping. This is the final ethical guideline of the FIGO Ethics Committee that I will focus in on. So stereotyping, harmful stereotyping undermines the ethical principles of equity, respect, and dignity. They are gender-based biases that can lead to discriminatory practices. Generally, there are many harmful stereotypes of women, such as women should be mothers, and therefore you can deny them access to abortion care. It's used as a rationale to deny care. Specifically with respect to rape victims, there are harmful guidelines that characterize rape victims as deceitful, and therefore one can require certification procedures. They must go through, get approval that they've been raped, and they will not respect the woman's statement that they have been raped. This is contrary to the WHO guideline as well as these ethical guidelines. Basically, one has to treat an individual according to that individualized need for care, not according to a harmful stereotype. Next slide. Now, in terms of training, bioethics training in reproductive health, there is a real need for further training, and hence I'm so pleased to be part of this session. There has been some very important bioethics training, for example, in Mexico, whereby Gustav Ortiz Milan and Francis Kissling have done bioethics training of healthcare providers, lawyers, and those involved in the delivery of care. This article by Gustavo and Francis is on our website under our section on the ethical and legal articles of the International Journal of Gynecology and Obstetrics. Their work has showed that a grounding in bioethics can help healthcare providers to have a ethical framework that supports the ethical delivery of services. And training healthcare personnel, lawyers, and members of ethics committees and members of hospitals and politicians has led to more ethical debates and respectful debates around this very contentious issue of abortion. So in conclusion, let me just say that there is a great deal of further work that is needed to take these ethical guidelines and make them a reality in women's lives. Thank you very much.
Thanks so much, Dr. Cook. That was Fascinating, and brought up a lot of issues that I'm sure we'll want to raise in the Q&A in a few minutes. So turning now to Dr. Mary Ellsberg of GW. Mary, please go ahead whenever you're ready.
Thank you. Can you all see my slides? Yes, great. So nice to be here today. I was just remembering that I was participating in one of these webinars a couple years ago talking about ethics in research on violence against women in conflict settings. And so I don't want to, I decided instead of repeating some of the same issues around safety and protection of participants in research, I would go in a slightly different direction. And just want to start by saying that since it's a relatively new field, research on violence against women, I've been involved in this kind of research for about 35 years. And one of the very early things we discovered and that we realized and that was really paramount for ourselves was making sure that respondents and interviewers were not placed at risk through research. And we became aware early on that women who disclosed violence, for example, were, literally their lives could be at risk for that, and at risk of reprisals from their husbands and or intimate partners. And together with the World Health Organization, we put together, based on our own experiences and practice, a set of guidelines that where the bottom line was, if you cannot minimize harm to both respondents and researchers, then you shouldn't do the research. And that at the time was kind of was considered controversial because we're thinking, well, this information is so important, of course we have to get the evidence. But the point was that it's not worth it, and it's not ethical to do if you can't really ensure that people will be safe. And so we were really concentrating on both physical, psychological, and social harm that could happen to respondents as a result of participating in the research, as well as both physical harm and vicarious trauma to researchers. And this is just a few of the guidelines that are now pretty much considered the gold standard for doing research on violence against women. And they have to do with, for example, making sure that you're not interviewing more than one woman per household, that men and women are interviewed in different households and clusters, to minimize the likelihood that abusers would find out about disclosures that have been made. But then another set of guidelines that have to do with making sure that we are providing referrals for specialized care to women who have disclosed violence, that educational information about violence is given to all participants, that we make sure that we have emotional debriefing for interviewers as well as technical debriefing, given the likelihood of vicarious trauma and the fact that many researchers have also experienced violence. And then more the social imperatives of making sure that results are fed back to communities and they're used for social change. And from the beginning, where we started practicing these recommendations was through the WHO multi-country study on violence against women. And we tried hard to make sure that the research was fed back and was used for, changing laws in the countries where it was happened, and also making sure that women's rights organizations were actively involved as principal investigators or co-investigators in the research. But our focus, I would say, was primarily on the principle of do no harm and mitigating harm. Over the years, I would say that this emphasis has changed somewhat, and particularly in recent research that I've been involved in, including through the What Works to Prevent Violence Against Women initiative funded by the UK government, we're going beyond the idea of doing no harm and really trying to incorporate feminist and decolonial principles into the way we do research. And I think that has been very exciting and very challenging. And these are some of the principles that we are grappling with right now. One of them, in addition to the do no harm, is is trying to ensure that our research is both collaborative and participatory, that we work with existing Indigenous movements and practitioners and women's rights organizations to build on existing data and evidence, that we are working with instead of on women and men, to think of the research process itself and the recommendations that emerge from it as a transformative process, and that we are explicitly trying to transform harmful gender norms and gendered power structures, that we are mindful and aware of and actively seeking to dismantle inherent power imbalances and take an intersectional lens, and looking not just at gender, but also race, colonization, class, disability, sexual orientation, gender identity, age, etc. And then the last two are really trying to maintain a spirit of continuous critical reflection, learning, and improvement as part of our research process, and that we are accountable, both the research itself and as researchers, to the local community. And then that the findings are made accessible, freely shared, and made accessible in a way that is meaningful to users and participants. So this all sounds great. How do you actually implement it? And that is not that easy. There's such a history of mistrust between of researchers by communities, and this is well earned. And so it takes some time and really sort of developing new practices to overcome this. And I just want to say very briefly, tell you a little bit about a program that we have been working on to document the impact of women's movements on policies to end violence against women. It's called the Weave Collective, Women Engaged Against Violence Everywhere. And it's a group of feminist researchers and activists from starting with South Africa, Australia, from the Aboriginal and Torres Strait communities, Nicaragua, and India, to try and understand to what extent women's movements have contributed to improved policies and to having an impact on preventing violence against women and girls. And we've been using feminist and participatory methods, using timelines, looking at historical trends, intersections with other movements, and political backlash. And what I think has been the most interesting is that we are really co-creating knowledge, not just through reports, but through documentaries, interactive websites, textiles, and other forms of art. And please give me I think I'm running out of time, so do let me know when I have just a minute to go.
You've got some more time.
Do I? Okay. So just to give you, I wanted to sort of give you a sense of what this has been like. We've been working with groups of Aboriginal and Torres Strait women in the Northern Territories of Australia, and with Dalit and Muslim women's movements. And for example, this Aboriginal group from Alice Springs has been reflecting their research findings in their art. This is a painting called The Seven Sisters, which is about solidarity among different women and women's groups. This is a beautiful painting done by one of the activists that it talks about, it's for weave, and it's how do women from all over the world come together, and up above there's the digging sticks, which are used for creating knowledge, and then the knowledge is all generated together and laid into this bowl for where the knowledge sits. So those are some examples, I think, of different ways of producing knowledge and expressing it. This was a timeline that we did with women's rights activists in Nicaragua, and we've been concentrating specifically on the last 5 years of repression by the Ortega regime, which has meant that most women's rights organizations have been banned, and most of them are in exile. And many of our colleagues in our group here, a research group, were imprisoned for up to 2 years in solitary confinement. This is a group of the ex-prisoners, women who, 2 years ago, who were released from prison and exiled to the United States. And they all participated in the research. And one of the pieces is specifically done by them to talk about their work and the experience of organizing and activism within prison. We are just coming out now with reports that pull together all of the research. But what I think is even more interesting, and for me has been personally incredibly fulfilling, is to be developing new ways of looking at these findings. So for example, in South Africa, after a participatory workshop, they've created an animated film about the history of the women's movement during different periods of South Africa's history, starting with resistance to the ANC's resistance to apartheid. And then we've started pulling together these stories and putting them into quilts. And this is where my own personal interests have really come in. My biggest role as a researcher, I think, here has been as a seamstress. And these are quilts that I've made from the stories and fabrics and paintings of the different women's groups. These were made by Indian feminist groups, and they tell the story of different women who have been resisting violence, and then we put them together with Indian fabrics. And then at the last picture, the last thing I wanted to show you was at the Sexual Violence Research Initiative, which was just last month in South Africa. We pulled together these quilts and a group of women from the Cape Flats Women's Movement and from all of our other countries. And we invited all the participants, over 1,500 women and men who were at the conference, to draw squares about their experiences and messages about women's resistance to violence, which was incredibly interesting and exciting. And there we were all sewing them together. And by the last day, we had pulled together a quilt that put together these different stories. And I think it's just a really new and meaningful way to start talking about our stories and our history and combining it with rigorous epidemiological research. And just to end with the slide, this was done by one of the ex-prisoners from Nicaragua. And it summarizes, I think, the values and the findings of that study, and also really speaks to the ethics of doing this kind of research, that solidarity, resistance, collective care, and hope are the key themes that arose. And I think that they should really can continue to guide us in the way we do research and practice. I'll stop there.
Thanks so much, Dr. Ellsberg. I'd never seen the quilting before. Thank you for sharing that. That's fabulous. And Dr. Strasser, please go ahead whenever you are ready.
Okay, hopefully you can all see my slides. Thank you for having me today. It's always tough to go last on a good panel, but I will be doing more of a focus on the US context, so hopefully you'll get a little bit of kind of different aspects of this issue. And I'm a health policy and health services researcher, and specifically will be focusing on some of the big picture issues that I think we're facing right now in sexual and reproductive health policy and research in the US context. So likely everyone on this call already knows that Roe v. Wade, which was the long-standing precedent in the US preventing states from enacting abortion restrictions, was struck down in June of 2022 as part of the Dobbs decision, the Dobbs v. Jackson Women's Health decision. And what that means is that states are now allowed to enact bans and other restrictions on abortion care. And so what we now have in the US is a rapidly changing patchwork system of abortion policies that are decided at the state level. And as you look at this map here, you can see that there are huge swaths of the country that essentially have no abortion access or severely restricted abortion access. And I want to talk about what that actually looks like on the ground. So first, I just want to note that we know from years of research that restricting access to abortion does not, in fact, reduce the need for abortion. Instead, what it does is it forces abortion seekers to jump through enormous hoops logistically, financially, emotionally to be able to obtain the abortion care that they need. Here's just one example from the TextPep project in Texas, illustrating what pregnant Texans were willing to consider as other ways to obtain abortion care, including driving, flying, obtaining pills online, obtaining pills from Mexico, obtaining pills from a clinic on a ship, rather than being able to get the reproductive health care that they can within their, that they no longer could within their own state, provided by clinicians who are trained and qualified to do so. And we also know that without access to abortion care, that the full scope of pregnancy care suffers. So it is the same set of procedures and medications and the same clinical training that is required for abortion care and for other pregnancy-related care, including management of miscarriage. So we know that in the US, between 10 and 30% of pregnancies end in miscarriage. Even before the Dobbs decision, Catholic hospitals had banned any termination procedures, whether that was abortion or miscarriage management. And there's significant documentation, both anecdotally and through research studies, to show that these policies led to life-threatening infections, significant bleeding, other serious adverse outcomes. You can see here on this kind of pull quote at the bottom here, this is from a piece that came out from our team in Health Affairs on the day of the Dobbs decision leak. This is just one example of a woman who's reporting that she lost nearly 40% of her blood volume during a miscarriage because she could not obtain the care that she needed in a Catholic hospital setting. Now, that was before the Dobbs decision. After the Dobbs decision, these policies essentially exploded across, especially those states that have restrictions. And immediately afterward, we knew what was going to happen. We could predict it beforehand, but we started to see immediately afterward, this is July of 2022, that there was confusion among hospitals, among clinical providers about what services they were and were not allowed to provide, including for life-saving pregnancy-related care. And the effects were not just on patients and their families, which were enormous, but also on providers who now face potential jail time, enormous fines, loss of their medical license for providing, again, not only abortion care, but also related care, including management of miscarriage. Now, this is in the immediate aftermath of the Dobbs decision. I probably could have filled the entire 10 minutes just with pulling headlines that have happened since then, but I particularly wanted to jump forward to the last couple of months and see where we are now in 2024. We have started to see reports of deaths. Here's one about a pregnant teenager, someone who was 18 years old, who died in Texas trying to get care in an emergency room, another woman in Texas, 2 women in Georgia. And I'm sure that we're going to just see this continue to proliferate as the effects of the Dobbs decision continue to play out. And I mentioned on a previous slide a little bit about physicians and clinicians generally and the effects there. I'm not going to read through this entire quote. If you're a fast reader, feel free to go for it. But I wanted to highlight this report called Care Post Roe that comes from ANSWER, which is at UCSF, and Brazan Research in Texas, describing the real ethical and moral dilemmas that healthcare providers are facing when they are qualified and trained to provide the care that they know their patient needs, but their hands are tied by policies, whether at the state level or confusion from their hospital or their health system in the way that those policies are being played out. And so I think this is an enormous ethical and moral issue that providers are having to grapple with. And these challenges in the post-Dobbs environment are layered onto existing threats to providers' physical safety as well as their moral safety, which already had been increasing in the years before Dobbs. So here's a report from the National Abortion Federation. Here you can see in this kind of yellow color, just some examples of threats that were posted online, so publicly available threats to providers of abortion care. You can see on the right here that these threats have been increasing over time. And in particular, I want to highlight at the bottom here, which I've circled, that there's a 20% increase in death threats and threats of physical harm just from 2021 to 2022. So that was before the Dobbs decision even had taken place. And I think as we start to see more and more data coming out about this, that we'll continue to see that these threats are continuing. So providers are facing enormous ethical dilemmas while they're also having to fear for their physical safety at the same time. And then, switching back to sort of the patient individual side of things, we also know in the US that we have a long legacy of structural racism here. And the way that plays out is that pregnancy outcomes are significantly worse for Black women in particular already. And we know from years of research that restricting or reducing access to abortion exacerbates these inequities even further. So what you can see here on the right, this graph is showing these gray bars are the current maternal mortality rates by race and ethnicity. And again, we can see here substantially higher for non-Hispanic Black women. That's what this second bar is about. And then the black bars are forecasting the increase in maternal deaths, again, by race and ethnicity. So we can see that it's up across the board for everyone, but particularly for Black women. And so we know that the effects of these policies will not be experienced equally across the population in the US. And then, you know, switching over a little bit to thinking about contraception, I think it's important to name that racism and medical paternalism play a role in access to contraception as well. We know from a lot of recent research that women of color and low-income women are more likely to be pressured to using long-acting reversible contraception and advised to limit childbearing relative to white women or women of higher income. And we take that on top of, you know, the shameful history that we have of forced sterilization here in the US, which again has greater effects on people of color and low-income individuals. We know that physicians performed more than 60,000 forcible sterilization in government-supported programs in the 20th century. And I just want to highlight that it's government-supported programs. So those are public programs that are meant to be safety net programs. And what we're finding is that there was these forcible sterilizations against the will of individuals who are obtaining them. And I want to say this is not limited to the past. So just two recent examples from 2006 to 2010, we know that about 140 incarcerated women were sterilized and that many of them reported significant pressure from both prison and hospital personnel. And in 2020, there was a whistleblower case that got a lot of national attention about non-consensual sterilizations that were performed on immigrants in Georgia. So this is the long and history and not so much history that we have to grapple with when we think about sexual and reproductive health in the US. Now, every time I talk about the Dobbs decision, I like to also talk about potential effects on contraception. I think historically, the perception has been that contraception is sort of a safe policy issue, but now with the Dobbs decision, we've seen that there is a blueprint for rolling back access to contraception in the US. So this is, and the lawyers on the call can feel free to parse this more delicately than I have, but this is from the direct text of the Dobbs opinion from Justice Thomas, stating that cases like Griswold v. Connecticut, which granted people the right to obtain contraceptives, should be reconsidered in the future. And so if that happens, we will find ourselves in the same position that we do for abortion now, right, where there is no federal protection for contraception. And if that happens, we don't know what the map looks like. It is possible that it looks exactly the same as the abortion map that I showed earlier. It's possible that it will look slightly different. But again, we know that there will be significant equity issues about who can access care and the quality of care that they need and whether their own preferences and will are being taken into consideration. And I think that is it. And I will switch it back to Melissa.
Thanks so much, Dr. Strasser. There's so much to talk about, right? Thanks so much to all of you. I think I will start with a general question that I put together from the questions that were put together, that sent in prior to the webinar, and a few of the questions in the Q&A. And I encourage audience members to please add your questions to the Q&A if you have not already. I'd like to address the idea of adolescence. So we have one question in the Q&A specifically from Mamadou, who says, in developing countries, often even after having reached the legal age, adolescents aged 16 to 17 must seek parental advice for their participation in a study. So this is specific to research, which Dr. Ellsberg, you might want to take. But then I was thinking about the application of the principles that Dr. Cook was talking about, as well as Dr. Strasser in the abortion field. So I think the idea of adolescence is a great area for us to start in.
Should
Yes,
I
go ahead, Dr. Ellsberg.
just say one quick thing, that this actually a colleague who's who's participating in this webinar, Dr. Zainab Eshak. I was just talking from South Africa. I was just talking to her this morning about this issue. She works with adolescents, and we were talking about intimate partner violence. And the problem in South Africa is that the difference between age of consent and mandatory reporting is different, so that there are laws that, for example, if you found out that an adolescent is experiencing violence, even if they're over the age of consent, and I think she said it was at age 12, they're allowed to receive services. But if they disclose violence, then there's a law around mandatory reporting. So I think that we have a situation where a lot of our ethical principles and legislation are actually in contradiction with each other right now. And that's a problem all over. And Zainab may want to say more about this, and she's in the audience.
Dr. Cook, Dr. Strasser?
Sure, I'll hop in and say that at least in the U.S. context, again, which is where I'm focused, I think I was limited on time, but I was debating about to add something about adolescents in particular, about being uniquely vulnerable especially in the post-jobs world, because all of the logistical and financial issues that people who have to travel for abortion care are magnified even further for adolescents and young adults who may not have access to transportation if they can't drive, for example, may not have money from a paycheck, may have to get parental consent for services, or at least parental, I guess, sign off for some of the services that they are seeking. And so I think that group is uniquely vulnerable in the post-jobs time. And we'll mention that I think there is, on top of that, a lot of fear and misinformation and disinformation that is uniquely affecting young people through social media in a way that maybe doesn't affect other age groups as much, related to like side effects of hormonal contraception and fears about those. And so there are, I think, enormous issues that are facing this population in particular right now, and being able to sort through those and support this population, I think, is really important for us to do as researchers, and thinking about policies that support them as well.
Thank you. Dr. Cook, you're still on mute. Would you like to?
So in many countries, it's very confusing in terms of authorization for adolescents to access reproductive and sexual health care. What happens with some healthcare providers, they'll import the age of consent from other areas of the law. And really what is required is that you should be looking at the adolescent's capacity for consent. So where adolescents have the capacity for consent, they can access, say, abortion care. So where they have the capacity to understand abortion or contraception, obviously the capacity to understand contraception is less than capacity to understand abortion, but they need to look at the capacity for consent. And the law is very confusing to providers, because what happens in the absence of specific requirements in the abortion law, what happens is they import the age of consent for marriage into the healthcare context, which is really not appropriate. So looking at this in the context of particular countries is very important. The work of the UN Committee on the Rights of the Child has been very illuminating in this regard, and I refer the participants to the general recommendations that they have issued explaining this.
That's very helpful. Could you repeat the name of that again? The Rights of the Child?
The UN Committee on the Rights of the Child, which is the committee that's established under the Convention on the Rights of the Child, to monitor state compliance. And they issue general comments or general recommendations outlining what it is to ensure adolescent access to healthcare generally, And that's in their general recommendations. I don't remember the exact number of the general recommendation, but if you go online to the UN Committee on the Rights of the Child, you'll see their general recommendations.
Thanks so much, Dr. Cook. Thanks to all of you. I would note that Dr. Ellsberg's colleague, Zainab Asak, has actually replied in the chat stating that the ethical legal norms often are not harmonized, which does create challenges for research and amplified by reporting obligations, which echoes what all of you have said, actually. I would like to pick up next on the idea of provider conscientious objection, which many of you have spoken to. And an anonymous attendee has specifically brought up the idea of how to ensure patients still get the care they need in countries that allow provider conscientious objection. I would also note that Dr. Cook, you spoke a little bit about conscientious objection, which we really have always in bioethics acknowledged as possible, and the idea of, yes, it's okay to voice objections and not participate in certain practices, but we want to avoid abandoning patients, which might involve recommendations, things like that. And I'm wondering what the three of you have to say about this. And I know Dr. Strasser in the recent abortion era, that there's a lot to say here. Also, Dr. Ellsberg in the international research, conscientious objection might show up in somewhat different ways.
I could start. First and foremost, I think what's happened generally in this area is those that are against abortion or contraception have captured this understanding of the right of conscience. We've forgotten that a right of conscience is available to everyone, women, patients, and providers who want to provide care. But it's been captured by a certain segment who want to use it to deny care. And in some cases, such as in Brazil, such as in Argentina, has recently proven by research there that they've abused it. There's several different developments in this. There's a case under the European Committee on Social Rights. So a group of Italian doctors who wanted to provide care brought a case under the European Social Charter and won against this, the government of Italy, because they hadn't structured their services in a way that would allow for doctors who wanted to provide care to provide care. They were really favoring those who were objecting. And because the Italian government hadn't framed this issue in a balanced way, those who wanted to provide care were working 24/7 essentially to provide care in areas of Italy where the objectors were objecting. And sometimes there's huge abuses. They'll object in the public sphere, but provide in the private sphere. Sometimes there's abuses in terms of providing, objecting, but not referring in a timely fashion. That was the case in Poland. So there's a great deal to be done on this, and research in Latin America has been looking at this, particularly in those countries that have recently liberalized their abortion law. But you'll see it as a form of backlash in many countries that liberalize their law. Another approach to this issue is to extend the scope of practice of different providers, say of pharmacists, of nurse midwives. So there are debates around, say, the scope of practice of nurse midwives. We're undergoing that now in Canada. There's going to be huge fights about who can provide care. And so expanding those who can provide care, who want to provide care, would be an answer to this. But that would require really more of a structural intervention, and some doctors who have now a monopoly on the care are going to fight that.
It's very interesting from trade organization perspectives, I guess, which, you know, we're
Exactly.
in the United States over many, many years, but now it's just a different area, right?
By the way, the decision of the European Committee on Social Rights is on our website. We have a whole website on abortion decisions, so it's there, that can be found.
Thanks so much. Dr. Ellsberg, Dr. Strasser, thoughts on conscientious objection?
I defer to Julia. I think it's more relevant in the abortion practices.
Okay, thank you.
I was just going to say, I don't know that much about other countries' contexts, and I think there are, but I think there are other questions in the chat that are very interesting if we can skip to the next ones.
Sure.
I don't want to take over.
Which one would you like to pick up?
I would love to answer the question about the Trump election, and I assume that there are also implications.
I was going to save the predictions for the future, right, to the very last one, but I think it might take us for the for the next 10 minutes. Please go ahead. Predictions in both research and practice. Yes.
Or I don't know if we're looking at the same question, but I was looking at what are researchers' biggest fears now that Trump has been elected. I think there is an enormous amount of uncertainty because about what can and will happen. I think abortion, I do not think we are done seeing abortion restrictions in the US in the next 4 years. I do not think we are done seeing restrictions on contraception in the next 4 years. But, you know, I talked about the idea of either a national ban on contraception, a national ban on abortion. Those are definitely potential ways that it can be restricted. But there are also, I think, a lot of other ways that are sort of sneakier almost to restrict access, and particularly for people who are uniquely vulnerable. So they can cut away the Medicaid program. They can make other cuts to safety net programs. In the US, we have Title X, which is a safety net program provided specifically for family planning. The first over-the-counter oral contraceptive became available in 2024, and there is a rule that is out right now about making that more, either eliminating cost sharing requirements for that or making it easier for people to get. They could change that. I think there are a number of ways that this administration can restrict access to what we know is evidence-based, person-centered sexual and reproductive health care. And I think the uncertainty is difficult, and I think it's sort of something that we'll all have to grapple with for a while, because there's a playbook for how to turn over abortion rights, but some of these other things, I think we haven't yet seen kind of the worst of what is to come. I'm sorry to end on to end that on a like kind of depressing note, but I think that's just a short list of some of the fears. I'm sure there are implications around the world as well.
I've got a few fears.
Right. Go ahead.
Well, I would say on the issue of sexual violence against women, just judging by the results of the election and the new nominated heads of cabinet positions, that this is not going to be an important issue during this administration, and that we can imagine that some of the most recent achievements, like the National Action Plan on Gender-Based Violence and the White House Commission on Gender Equality, will be, and then the reallocation of the Violence Against Women Act, which is coming up. I think all of these will be harmed by it, and then of course there's foreign assistance for both sexual and reproductive health and on preventing violence against women, which had really grown a huge amount over the last decade. I think all of those are going to be in jeopardy in the next few years, and that's something that has me very concerned.
Now, to add to what Mary and Julia have said, I think also this administration, the Trump administration, will try everything it can to compromise the work of the World Health Organization by withdrawing from the World Health Organization, defunding it. And that would be very, very unfortunate, because there are plans, I believe that they are already working on a new version of the abortion care guideline. So but the good news is that we do have this abortion care guideline, which is a very important document, and it's out there. It is a yardstick for different countries, and for different advocacy groups and the reproductive and health service providers to measure their services against this standard.
Thank you. And thank you, Dr. Cook, for that, the good news. Do we have any other good news that, or actually methods for moving forward, ideas for how our attendees can actually join us in moving forward during perhaps the next 4 years in the US, but certainly on the international front? Dr. Aylesberg, Dr. Strasser, good news, ideas?
You go
Join us in our work. Go ahead, Mary.
No, I was saying for Juliet to go forward. I think it's a little too soon for positive predictions, actually.
I'd like to see a lot more work at one of the values of ethics, in contrast to human rights, is that it's a language that healthcare providers understand. It's closer to the ground. It is a framework. It provides a space for respectful discussion. And you have some robust guidelines, but there are many other medical societies and OBGYN societies, nursing societies that could develop a more facilitative space for guideline development and application. So taking these guidelines, whether in the FIGO ethical guidelines or the ACOG guidelines, using the ACOG guidelines at the state level, applying them in court decisions. I think there's a lot of space there that these guidelines can be used in many different ways. So getting creative with the ethical approach to some of these issues, as has been done in Mexico, that Gustavo Milan Ortiz and Francis Kissling has done, as has been done by some OBGYN societies. That is a space for resistance, for advocacy, for normative development that we should not overlook.
Thank you, Dr. Cook.
The only things I would add are, I don't know if I would say that it's good news, but the things that give me hope at this moment are particularly our students. I feel like the young people, sort of the current next generation, whatever we want to say, are really fired up about these issues. And it is unfortunate that it's taken us getting to this place as a country in some ways for that to happen. But I do feel hopeful about people getting really engaged in this and being willing to dig into systemic prejudices that we've had and longstanding issues in this area, and being willing to go forward in a more sort of, forward-looking path, I would say, in the future. And I think the more that we have conversations like this and bring other people in, maybe if it's not your main area of focus, or just the more we're able to kind of be together and connect across different disciplinary areas, I think that will make this type of work kind of stronger going forward.
And I do agree that particularly in the work that we've been doing in showing how violence can be prevented and social norms can be changed, and social movements continue to do such important work around the world, that's also where I take my hope and reassurance. And many of them have been doing this work under much more difficult conditions, certainly, than what we're experiencing in the United States. And so we have many examples of hope and resistance continuing and being successful.
Well, I'd also like to say that in terms of what Mary was talking about co-constituting knowledge, there's been such a separation from the abortion field, from the violence against women field. And I think certainly the legal advocacy has a lot to learn from the violence against women field, and also the service delivery. I don't know much about the service delivery, but I'm wondering whether rape kits have emergency contraception in them, whether they have the abortion pill in them. So I think there's a lot of ways that we could facilitate access to information and knowledge that we could begin to forge in, say, those states that are receptive, in those countries that are receptive, that are working on with rape victims, because there's many ways that we can improve our own approach, and maybe this is the time we have to do it. In terms of, there's a lot of work, there's very exciting work that's being done on self-managed abortion care in different countries. And that's another area that we could be far more strategic in.
Thanks so much. And thanks so much to the three of you. This has been an outstanding hour. I've learned a lot, and I'm sure that we still have 117 participants, and we're like 1 minute over. So thank you. This is our last webinar for 2024. We will be hosting additional ones in the spring, starting in 2025. And you have two of them up here. There's one scheduled for February on research ethics in humanitarian and priority settings, and in March 19th, actually, ethics of animal research. We look forward to seeing you all again then, and thank you all. And then Trustworthy AI, also in March, and Clinical Consultation Service. These are our internal big forum hybrid meetings. Thanks so much for joining us. And there's a little bit more information about additional resources and for GW students about getting credit for participation today. Thank you all. Have a great rest of your week.